Hello, I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today and welcome to our Health Matters webinar covering coronavirus, Can We Pass the Test? Today we're going to be talking about the state of diagnostic and antibody testing in America and in your states. We'll look at where we are and where we need to go to reopen America. First, a brief scene setter. President Trump has been trumpeting his administration's accomplishments of late when it comes to testing, saying it is, quote, unmatched and unrivaled, with a marker of 10 million tests this week. But Senator Mitt Romney joined Democrats yesterday in taking the president to task, saying there is nothing to celebrate whatsoever about the government's record to date. In this webinar, we'll explore how the country is doing when it comes to testing and why it is so important for easing restrictions and reopening the country. We'll be talking about the reliability of antibody and diagnostic tests, the role of the Food and Drug Administration when it comes to oversight, and the debate over what assurances of immunity a positive antibody test can confer. And we'll help you map out strategies as reporters and policy thinkers for understanding the state of testing readiness in your state and what questions you should be asking to assess where we need to go from here, locally and nationally. Here to shed light on this, we are joined by two distinguished speakers. Dr. Michael Osterholm is an internationally recognized expert in infectious disease epidemiology and a leading voice during the COVID-19 pandemic. He is the McKnight Presidential Endowed Chair in Public Health and the Director of the Center for Infectious Disease Research and Policy at the University of Minnesota. He's also a member of the National Academy of Medicine and the Council of Foreign Relations. In June 2005, Dr. Osterholm was appointed to the National Science Advisory Board on Biosecurity. In October 2008, he was appointed to the World Economic Forum's Working Group on Pandemics. Apoorva Mandavilli has joined the New York Times as a health and science writer where she focuses on infectious diseases and COVID-19. She's previously written for The Atlantic, The New Yorker Online, Slate, Nature, Scientific America, and others. In 2019, she was awarded the Victor Cohen Prize for Excellence in Medical Reporting. Her focus is on stories about complex science through the lives of people directly affected by it. She also is the founding editor and editor-in-chief of the autism news site Spectrum. With Nidhi Subbaraman, she launched Culture Dish, a nonprofit dedicated to enhancing diversity in science journalism. She's also served as an adjunct professor at New York University's Science, Health, and Environmental Reporting program. This webinar is offered thanks to the generous support of the National Institute for Healthcare Management Foundation, the Commonwealth Fund, and individual supporters like you. You can tweet about the webinar at the hashtag #COVIDtesting. A word about our format today before we get underway. We'll be hearing from our panelists first in a discussion, and then we'll turn it over to you for your questions. Because we have so many people participating in the webinar, we'll ask you to write your questions into the control panel of GoToWebinar. You can also write us there if you're experiencing technical problems. And we will be archiving this webinar at centerforhealthjournalism.org. Now, let's turn to Dr. Osterholm. Dr. Osterholm, this week, Senator Lamar Alexander said all roads back to work and school go through testing. Can you help us understand where we are currently in the effort to ramp up diagnostic testing for COVID-19 and our chances of achieving, what is a kind of moving target of the right testing level?
Well, thank you very much. Thanks for having me. I appreciate the opportunity. Let me just make a general observation about the comment from the senator. Lewis Carroll once said, if you don't know where you're going, any road will get you there. And I feel like that's exactly where we're at right now. There are at least 42 states that are about to open up or relax the restrictions on physical distancing, opening businesses, etc. And even though just a few weeks ago, one of the criteria upon which the White House at least had identified that states should consider before they do that is that they have at least 14 days of a decreasing number of positive tests using the standardized testing method. And I don't know one of the 42 states that are using that right now. So as much as we talk about we're trying to test our way into some kind of status with this pandemic, I think the rhetoric and the practice are far apart. I think also there's a great deal of misunderstanding about what a test can and can't do. We have a paper coming out very shortly that will actually address this in some detail from our center, talking about smart testing. In other words, a test is not just a test, is not just a test. It's you need the right test at the right time for the right person, for the right result, for the right action. And it's much more complicated than just, did I test 8,000 people today or not? So in summary, let me just say that I don't know where we're at with testing, because as much as we talk about it, I've not seen it used in any meaningful way in recent weeks that would suggest we have any idea what we're doing.
That doesn't sound very cheery. Let me just go to one number that's being bandied about, coming from the Harvard Global Health Institute, which published data earlier this month looking at how many tests each state should be doing as part of their strategy to begin a slow reopening. And Harvard found that fewer than a dozen states are ready, but that's with a standard of 900,000 tests per day. I think we're around at 300,000 per day, but there's been estimates that we need many more. So what should we even think of as, to your point, the standard for the correct standard for what we need in testing?
Well, at the risk of suggesting that there's more confusion than there is fact with all of this, I have had a chance to look at all these test recommendations that have come out. We have looked at this very carefully ourselves. I've written about some of these issues. I don't know in the first instance where many of these estimates come from. If you're doing smart testing, it's not about the number of tests you do. It's which tests you do, and then make sure that you can assure that all those tests are being done. So to come up with an arbitrary number to me has already by itself been a misplaced priority. And I've seen that happen over and over again, where people just say, it's almost like a poker game. I'll go for 8,000 a day. Well, I'll go 10,000 and call you. I think that this has been a real challenge. What is the purpose of testing? Whether you're testing for the virus, whether you're testing for the antibody, what do they mean? How do you use them? And so I've been very concerned that we've put numbers out there that are coming from groups that when you actually attempt to articulate what the purpose of that testing is, what does it mean? For example, I will tell you right now, the single most important test that we can do is one for the virus, a PCR-based test like that, or hopefully a reliable antigen test for people who are getting sick every day. When Willie Sutton was asked why he robbed banks, he said, because that's where the money is. If we want to know what's going on in our communities, what's going on in our states, we're going to be testing and making sure that we can test every person who has any symptom today in our communities that might suggest a COVID-like infection. If we can do that, whether I have 2,000 tests or I have 20,000 tests, I need to be able to test every one of those. I need to be able to test healthcare workers and first responders who are having patient contact if they have any symptoms at all that might be the early signs or symptoms of COVID infection. I can go through the list. But when it comes to absolute numbers, if we're really successful, we should be driving down the number of tests based on the actual infection in our communities. And so I think that we need a lot more than just some of these recommendations that have come out, and to explore what it is that we mean by testing and why are we doing it, what's the purpose of it, what will be the outcome of it. Also, I want to add one last thing. I hear about all these tests and I ask myself, well, what are you going to do with the data? What just to have a test is not just a meaningful thing. So I think we have a lot of issues yet to work out, and we have embraced testing, which is very important. Don't let me minimize it, but we've embraced testing akin to what I saw after 9/11, where everyone kept saying, in Cipro we trust. Today it seems like the motto is, in testing we trust. And I ask people what they mean, and they don't often understand what they mean.
And a question for you, Apoorva, how are you handling this kind of uncertainty in just, what even the standard should be? How do you handle that in your reporting and in your writing?
I think when you see numbers like the Harvard report that says X number of tests per day, one of the first questions to ask is for whom? Because every state is different. Every state has different levels of the epidemic right now, and every state has different population, different kinds of workforce, different considerations. And so you really need to look at that. to Dr. Osterholm's point, also, you could do the tests, but then what happens to the tests? I think in a lot of cases, in the early days, the CDC was insisting that all the tests be sent back to them, or even when after that happened, for somebody to get the results from a test took several weeks. So I think the questions that journalists should be asking is not just, did somebody get tested, but how quickly did they get the results? What happened after they got the results? Did the results get back to them in a timely fashion? And then was there follow-up from the clinic that tested them so that there was some level of isolation and contact tracing? All those things matter. And also, I think how good a test is a really important question to ask, because as Dr. Osterholm said, a test is not a test. I mean, we have the two kinds of tests, the diagnostic virology test and the antibody test, but within each category, there is a huge range of quality. And both of those tests are riddled with errors, depending on which manufacturer made them and who validated them. So those are all the things that journalists should be looking at, instead of, just the number of, we have X number of tests available, or we need X number of tests per day.
A question for both of you. Apoorva, you talked about almost like a decision tree. Once a test is done, what are the things that happen after that? So who is setting those guideposts right now? Do we know what the answers are and they're just not being communicated? Or is it a matter of just how unknown this pandemic is, that we have procedures in place, but we're not sure what those decision trees should be?
I can answer that for, at least for antibody tests. I think initially the FDA didn't really set any parameters, partly because of confusion around the diagnostic test, because there were complaints and criticisms that that test was too slow to roll out. They sort of let everything in with the antibody tests all at once. So it was, as Dr. Osterholm very colorfully told me, the wild, wild west at one point, with every company basically coming out with an antibody test. I mean, my inbox was just flooded with dozens of emails from tests claiming to do anything that you wanted, basically. But I think the FDA realized that that was not sustainable, and that communities and even national governments were starting to use antibody tests as a way of justifying reopening the economy. And so they slowed down. They put out a change in policy at the beginning of this month, saying that any company that says it has an antibody test can't just let the FDA know it has a test. It has to actually apply for authorization from the FDA. And that has immediately sort of cut down on the number of tests proliferating in the market, because now the FDA actually has to look at these tests. Separately, the FDA was also working with the NIH to validate some of these tests. So now we have a little bit more quality control going on, and you can actually go to the FDA website and look up which tests have been validated in this way and what their accuracy is and what their specificity is. So we have a little bit more information than we did in the early weeks.
And
yeah, and I would just add to that. I think that you did a very nice job covering that piece. And again, it comes back to what's the purpose of the testing? What population are you testing? When I hear about locations that have potentially high impact positions, you can imagine who we might be talking about if you can. What if you have a test that can pick up 95 or 96 out of every 100 that are infected? Might be considered a good test. But if in fact you can't have anybody infected in that environment, then you have to ask yourself, how good is that test? Because if I have to test 1,000 people a day and 3 or 4% of them are potentially infected and positive, and I will miss that and the test calling it a negative, you might expect that you might see workers or visitors or anyone else in that environment show up positive. And so what is the purpose of the test? What are you trying to do? If it's that, using that test as the gatekeeper, then you know you got a problem, because it's not going to be perfect. I liken it to fixing 4 of the 5 screen doors in your submarine. You still got a problem. And so I think that one of the challenges we also have to ask ourselves, what kind of testing and for what purpose? If you're just trying to look at clinical cases in a community, it surely is important to every individual patient. But at the same time, if you can get 97% of the ones right, that's a big, big step forward, where you will absorb maybe 3% that are not positive. And so one of the challenges I've had is this is where you have to define your population you're testing and for what purpose. This is where, again, we come back to the concept that we call smart testing. It's more than just the test itself. It's the purpose, it's how it's being executed, it's what you're going to use it for, and what are the consequences if you do or don't have the right answer. And we seem to have missed a lot of that discussion. And I think other than what we say with Apoorva here and others, at the Times, there haven't been necessarily enough stories about that very piece of just, don't tell me how many tests we're doing today. Tell me, what are you doing with those tests? Why are you doing it? What difference does it make? And what did you miss that you should have done that you didn't do? That's, I think, the heart of what we're trying to get at.
And let me try and take this down to a more specific level. One of our most vulnerable populations really around the country are people who are living in nursing homes and assisted living facilities. And yet it was only within a matter of weeks that here in LA County, for example, there was a mandate that everyone there in any facility, from workers to people who are living there, should be tested once a month. And I wonder what's happening in other jurisdictions and what are the kinds of protocols that should be in place and who is setting them. What questions are you asking, Apoorva, as a reporter around these kinds of things? And Dr. Osterholm, what do you think policymakers should be doing?
Go ahead. Oh.
So, I mean, I think, there's no question now that we know that nursing homes and prisons and homeless shelters are all sort of clusters of infections. And, there have been more deaths in nursing homes in the United States and in Sweden than anywhere else. And I think it took a while for everybody to sort of figure that out. But also, I would say once a month, what is that going to do for you? Whenever we talk about these tests, even when Dr. Osterholm was talking earlier, he was mentioning testing by symptoms. That's because the US is still at a stage where all we're able to do with the number of tests we have available is still just get to people who are showing symptoms. In a place like a nursing home, by the time somebody is showing symptoms, that means, we know now that people are most infectious 1 to 3 days before they start to show symptoms. So if you're only catching somebody after they have symptoms, they've already passed it on to a ton of people that they're coming into contact with. And in a high contact place, like a nursing home, that virus is going to spread like wildfire before you've even started to know that it's there. So again, these policies have to make sense within the context of what this virus is, what the tests can do, and who's being tested and how often.
And I agree 100% with that. I think that's exactly the kind of discussion we have to have. What does once a month testing do for you? If you have a very high risk area, you basically need to know on a much more frequent basis if the virus is entering. Remember, again, nursing homes, as I pointed out, as well as prisons, meatpacking plants, you could have 1 out of every 200 people in the community infected, a 0.5% rate of infection. But if one of those 200 comes to work at that nursing home, or they're a visitor at that nursing home, suddenly that is a match into the gas can. And you will have 30, 40% of the people infected with the result of transmission. So where you have to look at is not just testing, but also what other kinds of screening controls are you using? What else are you looking for? What other infection control processes are you looking at? One of the challenges we have right now in long-term care is that if you look at the workforce there, they're often paid minimal above, minimum wage, if that. And there are very few benefits, and more importantly, there's very little in the way of infection control prevention activities going on, including protective equipment for the workers, detailed protocols for infection control, cohorting of patients that may have similar symptoms. And so while testing is important, and I think we've already established that, it's not enough. If you think you're going to test your way out of protecting people in these facilities, that's not going to do it. It's important to start. And that's where I talk about testing in the context of what does the result tell you? If you do pick up somebody in a long-term care facility that you're testing because now you've mandated that, do you have infection control practices? Do you have experts that come in and help? Do you have adequate help themselves? I'll tell you, there's an increasing number of long-term care facilities that don't even have nearly enough employees. What should be 5 times the employee number that they need to have are not, they're not there. They're in a minimal work staff. So I think that this again has to be part of the solution of not just putting everything onto testing. It's critical, it's informative when you use it in these areas, but if you can't tie it to all these other actions, I don't know why you're doing it, because you're documenting a train wreck, you're not preventing one. And that, I think, is an important issue that we keep missing with test or no test.
And Dr. Osterholm, what level of guidance do you think the federal government should be providing on protocols for all this? We heard a question in a Senate hearing yesterday about, states feeling a little bit left on their own here.
Well, unfortunately, states are. One of the things that CDC has done very, very well over the years is provide guidance in areas like this. And I have never known a time where guidance coming out for part of a community-wide outbreak, or in this case, a nationwide outbreak, weren't just automatically brought from the science side of the house and made public, as opposed to just, the political interpretation or however. We need this information. We need to standardize it. I think there are many people out here of great goodwill. They want to do the right thing. They're looking for direction. And, we don't have an expert to put into every long-term care facility in the United States right now. We don't have an expert to put in all prisons and meatpacking plants and places like that. We don't have experts even in many cases to put in our hospitals in ways that could be helpful in planning what needs to be done. And so having this written guidance, these kind of milepost guidance documents are critical. So I can't say enough about their importance. I can't say enough about how CDC has, and they have surely put some documents out that are very helpful, but we need more help that way. And this is where I have been voicing for months the underutilization of an incredible, critical national resource, the CDC, in helping to standardize this. Why should 50 state health departments or another hundreds of city governments all have to figure this out on their own? I don't think that's what we want. And that includes how to use testing.
And Apoorva, for reporters who are trying to get a sense of how well their states are doing and how well their local jurisdictions are doing, what kinds of questions should they be asking given the lack of sort of federal guidelines in some of these areas?
I think the questions they should be asking is, what exactly are they doing, and what are they basing that information on? What are they basing those guidelines on? As Dr. Osterholm said, it's very important that things be based on science, and the CDC has traditionally done a really good job of that. But in a case like this, in a pandemic like this, where things are moving really quickly, there isn't always time to gather all of the evidence before coming up with a certain, roadmap for how to treat people in a nursing home, pregnant women, children, schools, whatever the case may be. And so what's happening, I think, in the absence of really clear guidelines from the CDC is that these states are taking best guesses, and every state is sort of coming up with its own playbook for what they're going to do with schools, when to close them and things like that. I think the questions that journalists should really be asking are, what's going into your decision to do this? What are you basing that on? What evidence are you looking at? Which experts, which public health epidemiologists have you consulted with? Or is this just being something that's done in closed rooms by politicians? Those are some of the things that journalists need to ask.
And I might add kind of a supportive piece to that answer is the fact that if I were a journalist, I would start at the back and work forward, not forward to the end. Meaning is, my goal is to prevent anyone in a long-term care facility from becoming infected. Because once they are, the consequences of that are obvious and often something we can't change. So the questions I have are, what are you doing to make sure that these infections don't occur in these facilities or any other place where high-risk people are at? And then testing backs into that. It's not the question of what are you testing with the idea that that's the answer. It's the entire portfolio of what are you doing, of which testing should be a very important part of that. And I think work backwards and then find out, so what means this with respect to preventing these cases? What does this mean with respect to preventing these cases? And in some situations, we just have to be honest and say that as a nation, we have so undervalued the kind of care that we provide in long-term care facilities. Look at the people who work there. Look at what they get paid. Look at the training they have. Look at the protective equipment. We have had long-term care facilities throughout this country where not one person in the whole place had an N95 respirator upon which to then work on under some kind of safer conditions. And so I think that that's part of the answer too, is testing is going to come up, but where does it come up in the context of a composite picture of what we're trying to do and why?
Thank you. And, we're in an interesting situation when we look at this outside of the U.S. from an international perspective. And we've seen some countries that have done very well compared to the U.S., but some of those same places are now struggling as they reopen. They're seeing some spikes. And so what are some of the lessons that we could learn both from what they've done previously and this kind of delicate stage of trying to ease things and to reopen things?
Well, let me just use the United States as kind of the example, and then we can talk about the rest of the world. But right now, our best estimate is on using studies that we have that between 5 and maybe 20% of the population has been infected, and that 20% is a very isolated geographic area situation, such as potentially New York. The vast majority of this country is likely at about 5%. Not inconsistent. Today, they just announced in France, using some pretty comprehensive studies, that they may be at 4% overall in France. When you think about the fact that this virus was made to transmit to people, it was made to find people, it was made to infect them. And I say made, Mother Nature has done an incredible job of making that happen.
I was just about to say that, just to stop the conspiracy theories.
Yeah, I want to be sure this is not a man-made virus, but it's what was made by nature. Thank you. But I think that the challenge here is that it's not going to slow down its transmission until we get to at least 60 or 70% of the population infected. This term we call herd immunity. And you can argue about what that number might be. Based on the transmission characteristics, we are quite convinced it's in that 60 to 70%. Well, think of all the pain and suffering and death, all the economic disruption that's caused all so far with this very low number and where it's going to go to. So one of the challenges we have is understanding how do we get to this herd immunity level, whatever. And this is what I call a leaky bucket virus. If there is one micro hole in that bucket, that virus will get out, it'll escape. And so areas of the world that have basically had programs that clearly had increased testing, contact tracing early on in smaller numbers, did have much more success in trying to control or at least minimize the impact of this infection. But as you just mentioned, as you see, whether you're talking about Singapore, you're talking about Seoul, even in China today, where we now have infection being transmitted back in Wuhan again, this is going to continue to keep transmitting to people until it somehow gets to that 60 or 70% level before it slows down, not stops. And I think that we just have to acknowledge that. And I've said, and I may surely one day go back and rethink this comment, but I feel like, we're not directing this tiger, we're riding it. And so while I believe that the actions of distancing have had a big impact on shaving off the peaks that we could have had this spring, and I fully support that approach. Overall, this is going to do what it's going to do. And, it's like viral gravity. We can't make it stop. We can only try to minimize how much and what happens. And the whole purpose of trying to minimize it is not to say that, we're going to prevent you from getting it. We're trying to buy time right now until we can possibly get a vaccine that can get us to that same 60 or 70% protection level without having to go through the disease and all that occurs because of it. So I just have to say that anybody who thinks they have the perfect model, just give it a few months, okay? And let this virus keep floating out there and then come back and talk to me about the perfect model.
I will just add that none of that should have come as a surprise to us, that when these countries start to reopen, we start to see a surge in infections. Epidemiologists have been saying that, like Dr. Osterholm have been saying that since the beginning. This pandemic is going to go in waves. when we are on lockdown, when we are practicing social distancing, when people are staying home, we'll see the curves plateau and maybe even start to go down. When we open up, we'll see it go back up again. And this is going to keep happening in waves for the foreseeable future until we have a vaccine.
And let me just add a context to this, because I think it's also very important we acknowledge what we know and don't know. Back in December, our center at the University of Minnesota started following this situation very closely. And because I have worked a lot on SARS and MERS, both in the Middle East and in Asia, you know, I've immediately rushed to judgment and said, well, this is going to be a tough one, but we'll solve this one, because if it's like SARS or MERS, it's very clear cut. What we have to do is identify cases early. They won't be highly infectious till day 5 or 6 of their infection. We get them isolated, find their contacts. We'll get this all taken care of. And then it became clear by literally the end of the first week of January that this virus was acting much more like an influenza virus. It was person-to-person transmission, unlike what we'd seen with SARS or MERS, that there probably was a very early infection component to transmission, even to the point now where we understand about the asymptomatic or pre-symptomatic transmission. On January 20th, we actually put out a document that said this was going to cause a worldwide pandemic. I mean, we knew it then that all the characteristics were there. Nothing in any way, shape, or form would suggest that that wasn't going to happen. A week later, we put out a document that basically said, based on the time it takes for cases to basically be transmitted from one generation to the next, a period of about a 5-day incubation period, and the fact that even if we looked at the doubling of cases, 1 to 2, 2 to 4, 4 to 8, 8 to 16, it was probably going to take a good month with this virus circulating around the world before people recognize it's even there. And that when it would happen, we would see if this was an influenza virus-like model, knowing this is a coronavirus, not an influenza virus, it wouldn't just uniformly infect all places at the same time in the same way. If you look at 1918 influenza pandemic, for example, Chicago and New York got hit hard in an early wave. Minneapolis, Detroit, Boston, Philadelphia, Baltimore, none of them did at all. And then the virus suddenly almost disappeared. Not through any human activity, not through any control effort. That wave ended. And we went into a quiet period for several months, which no one at that point necessarily thought it was coming back. And then, of course, that wave, that second wave hit, and it was devastating. And then everyone was in the soup at the same time, with the irony of, of course, Chicago and New York had got hit less hard because they already had so many that had protective antibody. I bring this up because we don't know that this is going to do that. This document that we put out from our center several weeks ago on scenarios, we said it could easily be just a coronavirus model that we've never seen before, where we just keep having these little bumps of cases, kind of like a foothills type thing, up and down all around the world. Or it could be one where just we go in slow burn, basically just, you know, just keeps happening and happening and happening. Or it could be like an influenza model, where we have these initial cases, this activity, and then it just goes away on its own, which will, of course, we'll claim victory if it does. That's what would scare me more than anything right now, is if we suddenly saw it go quiet. Now, that may seem counterintuitive, but if that happens, I can say the chances of having a big peak, you know, several months from now, I think is a real possibility. That peak is what would redefine us as a human race in terms of what it would do to us, in terms of number of cases, what it would do to our communities, our economies, etc. So even there, when we talk about how we're going to try to prepare for the future, what are we going to try to do to control it? If we have a huge peak of cases that occurs with this, there won't be enough physical distancing we can do that will actually stop that. What we can do is surely shave the curve again, hopefully, trying to get us closer and closer to vaccine availability. But I can tell you with certainty, we will be riding the tiger. We will not be directing it. That's something that people don't understand yet. There is this mistaken belief that it's just a matter of tension between the private sector, business, public health, and medicine. And if we just get that fine-tuned, we can control this thing. And we don't know that at all. So that's where I'm now beyond my headlights. We were covering things pretty well up till now. I don't know what the future holds. I just know with viral gravity, this virus is going to keep trying to get to that herd immunity level. And we have to understand that.
And the degree to which so much is unknown about the shape of all this, it just seems like it also poses a tremendous challenge for reporters. You're trying to assess, Apoorva, what does new normal mean? How do you do the new normal responsibly? How do you reopen responsibly? And so where do you go, given the wide range of possibilities that have just been laid out here by Dr. Osterholm?
Yeah, I mean, it's not an easy thing to cover this pandemic because there are so many unknowns. I mean, I'll give you an example of whether schools should reopen, which I wrote about recently, and I cannot tell you the number of emails and messages I've gotten about how wrong I am because there's this other study that shows something else, and here's this other study that found something else, and this other country is doing this other thing. In my piece, I talked about two different studies, one that looked at sort of viral load in kids and said they seem to have about the same amount of virus in their throats as anybody else who's infected. There's no reason to think that they wouldn't be passing it on just as much, even though they don't get sick, because now we know people, adults who don't seem sick can also pass it on. And there was also another one that said, kids seem to be less likely to get infected, but they're exposed to a lot more people when they're in school. So overall, it sort of argued against just reopening schools without thinking about things too much, about how to reopen schools. But in the meantime, there are governments all over the world who have come up with other decisions. The Dutch government did its own study, and it's not a peer-reviewed study. It's just posted on a website. There are just some results and some data with not enough context to really be able to judge what it says. There's, the Australian study that somebody else, has done, and that looked at schools, and they did looking at some household clusters, but that has its own problems. And then, Iceland did something else, and Germany is doing something else now, opening their schools. So it's like you could take any aspect of the pandemic, and there are just as many opinions and voices and studies and incomplete results that you have to look through to figure out where the truth lies. And that's a really hard thing to do. So I think, there's no easy answer to it. I think I've been basically trying to apply every principle of science journalism that I know, looking at studies as carefully as I can, trying to see which study is good, which comes from a reputable lab, which, doing my own sort of peer review, sending it out to other scientists to say, can you look at this? Can you tell me what you think of this study? Is this one I should pay attention to? Those sources that you can trust become really important in a case like this, where the studies themselves have not already been vetted by a thorough peer review. So it's a fire hose of information. It's a lot of preprints and a lot of Twitter threads and a lot of speculation by politicians, and a healthy dose of skepticism and a lot of vetting by experts can get us part of the way, at least.
If I could just add on to this comment, because I think this is important for those listening here, that you've just heard from a really good reporter. As somebody who deals with lots of reporters, and how many of them have done their homework, how many of them have tried to understand the issues, how many of them are going in with the objectivity of, I don't have an answer yet, I'm waiting to let the data, the facts, the story unfold, as opposed to, I have a story that this is what I want to write, how do I go find the quotes for it? And I know that that's not at all acceptable in journalism, but it happens. And it happens, unfortunately, in an event like this all too often. And I just want to compliment you. I think that what you just shared is exactly what people like myself are willing to invest in, because our job is to get the message out. One of the things I would also say is, and you know this too, that, I'm willing to help any reporter I can within the context of time. I don't need to be quoted. What's important to me is getting the right information out. And if I don't know the answer, who can I send them to that I know that might have the answer or the issue? And so I hope as reporters that you use that model and basically find the experts you can trust. And if they demand to be quoted or are disappointed if they're not, then already you got to wonder, what they're saying and for why. And second of all, you've got to do the kind of homework that you've done and done so well. And her stories reflect that very, very much in terms of what's been out there. So thank you.
Thank you very much. I think, for any journalist, as any journalist knows, we're only as good as our sources. And so I think it's been incredibly helpful during these last few weeks and months to have sources who are willing to respond, as you have been, and some others have been, to be generous with cell phone numbers and do phone calls at 9 o'clock at night, or whatever is necessary, and to provide that kind of information. It's been really invaluable.
We're going to open it up shortly to your questions. I see some questions that people have entered into the control panel. I just want to welcome others to do that as well. And before I turn it over to our audience, I wanted to follow up on some things that you both said. Apoorva, you talked about this idea of how you're assessing the credibility of information. And I think it might be worthwhile to take a step back, partly because so many people are now being expected to sort of be de facto health and science reporters without having really had much time for an internship period. What would have been, before this pandemic, a normal process that you would go through to assess, the credibility of something, and how does that change at a time when the normal process of vetting that takes place by, say, medical and science journals is being supplanted by preprints? Maybe just even explain that distinction as well.
Sure. So usually when scientists do a study, they take weeks and months to write up the results, and then they send it to their colleagues and to their teams to look at and read and revise. Then it finally goes to a journal, where the journal will send it out to other experts, usually 3, sometimes 4, for them to review the results and say what else that original team of scientists should do. Do the results make sense? Does it all sort of look okay? And often they suggest extra experiments that the team should do. And then, some journals have professional editors to polish the copy, make it sound better, put it all into context, and then finally you get journalists get an embargoed press release, from the journal saying you have 1 week to report on this. This is coming out next week. Well, since the coronavirus, none of that has happened. Basically, the second people have results, they're writing them up and throwing them up on these websites. They're called preprint servers. There's one called bioRxiv for biology preprints, and one called medRxiv for things with more medical significance. And essentially, you can now find hundreds and thousands of papers on those preprint servers that people have been submitting. So they're doing that first, which was a trend that was happening even before the pandemic, but it has really sped up in the last few weeks. And we reporters are now looking at those preprint servers. I mean, before the pandemic, I would not have looked twice at a paper that was, that had 5 people in a study or 14 people in a study. Just no, I wouldn't even have looked at it. But now, 14 people donated convalescent plasma. It's like an exciting paper. I'm going to look at it carefully, and even if it's on a preprint server. So that's why I said that journalists doing their own peer review becomes so important, because I am trying to get copies of these papers, sometimes even before they've gone on a preprint server, trying to get them out to my sources that I trust to say, what do you think of this paper? Does the science here make sense? Does the results make sense? What are the caveats? Is this a big enough number of people in the study for them to draw these statistical conclusions? Does the analysis hold up? And that has been, a very stressful and urgent thing to be able to do, because the information is coming out so rapidly. And fortunately, at a place like the Times, I have the luxury to be able to say, I'm not just interested in being first. I want to do this right. And we take accuracy incredibly seriously. But at the same time, it's dismaying to see other publications, which I will not name, come out with, a single source article, interviewing a microbiologist about, something that completely unrelated, or interviewing, a cell biologist about viral immunology, even though they may not, be studying anything to do with viruses. Just really badly done journalism. I have to say, overall, I think the journalism during this period has been great. There have been just amazing people doing amazing work at a lot of different outlets. But I think that takes some giving up of that desire to be first, and to say it's okay if we don't have this first, but it's really important for me to make sure that I know that the information in this preprint that hasn't really been looked at by people has valuable and accurate information.
Thank you. I'm going to turn this over now to our audience. We have a question from Glenn Melnick, professor actually here at the University of Southern California, who asks, is there any safe way for universities to reopen in the fall and to have even limited in-class meetings?
Well, let me just say I've actually been advising several groups of higher education presidents and organizations in this regard. I also, besides being at the University of Minnesota as a professor there, I'm actually on the board of regents of Luther College, a private college in Iowa. So I've been getting this from every direction. My message is, and continues to be for everyone, plan as if this pandemic is not happening. In other words, plan like you're going to do what you're going to do. And then once you get that done, plan like the pandemic's going to happen badly tomorrow. Maybe it's the first week of August. Maybe it's in September. I don't know when, but it's all about flexibility. So we could be frozen into inaction right now, saying we won't do anything because we have a pandemic. And I think that's the wrong approach. So, you know, we could be in a totally different world in September. And we could be basically on the tails of where we're at right now. We just don't know. So I would say that the colleges and universities I've seen that I think are farther along and really in a sound footing of what they're planning for is, one, they're planning to do the best they can, but also planning with uncertainty. For example, creativity-wise, I've seen colleges deciding to go to block credits, meaning that they're now going to do intensive studying for 1 or 2 weeks, one class. And then if they have to drop it after that, at least you've gotten that one done. Whereas opposed to if you're taking a full load of 4 or 5 classes and then in the middle of the semester it ends, what have you gotten out of that? What have you accomplished? Second of all, I see them doing much more distance learning, but I think we're all realizing that's more complicated than it seems. You know, the internet is a gift, and the internet doesn't, however, necessarily give you everything you want. And so I think that we've seen that. So I think the message has got to be loud and clear. There's no one plan for reopening. Plan as if you're going to, plan as if you're going to move forward, but also plan for that plan to be changed and to be able to respond quickly.
Oh, you're on mute.
We have a question for you, unless you wanted to weigh in on the university question.
No, I mean, I think, you know, he's right. It's more complicated than day schools because you have all these young people in dormitories and in clusters, and it's just, you know, if it's just classrooms, you could do kind of what Germany's doing, you know, set the desks apart, or you could do what China's doing, where they actually have these shields around each student. I mean, there are crazy things that are being tried, but it's the dormitories and the sort of general nature of young people to congregate in groups that makes it really complicated to figure out what universities should be doing, because you can mandate only so much in terms of what they do within the classrooms and what happens when they socialize, and, you know, how do you police that? It becomes, I think, very tricky.
I think if I could just add one additional comment, you know, I didn't comment on this before, but also it has to take into account the fact that, yes, students make up the large part of any person population on a college campus. And on average, they're younger. They're in those age groups that we would not expect to see anywhere near the same incidence of serious illness or death. But colleges and universities are also made up of faculty. They're made up of staff. They're made up of administrators. And they do have individuals there that are at increased risk. And the balance is, you can't have a college or university operate with no faculty or a selective group of faculty or administration, et cetera. So, you know, on one hand, universities and schools, you know, high schools and grade schools are surely at a better position kind of assessment in terms of those individuals having severe illness. But when you start adding in the teachers, administration, et cetera, it does change the picture that you have to now think about that.
And a question for you, Apoorva, from Tiffany Cassidy. She says, what is your approach to covering poorly done science during the pandemic? For example, science with poor trial standards, or scientists confidently stating something that might become quickly disproved with more research.
I mean, I don't cover it. I think before the pandemic, there was some argument for covering studies that maybe got widely picked up and doing a sort of a second day story, really sort of taking it apart and looking even at the media coverage of that and saying, this is what all these places reported, but here's what the study actually shows. But now with the amount of information and the number of studies that we need to cover, there's just really no time to even pay attention to ones that aren't very good and won't stand the test of time.
We have a question from Joyce Frieden, who says that the New York Times published a piece today suggesting that at a 5% level of COVID-19 infection, an antibody test that was 90% accurate would give a false positive rate of 70%. How accurate does an antibody test need to be in order to be useful? And are there any tests like that out there or on the horizon?
Okay, I didn't fully make sense of those numbers, but I would say, it depends on what you're using it for. Again, if you're using it to reopen the economy, then there really isn't a lot of margin for error. You need a test that is close to 100% specific, 0% false positive as you can get. And there are actually a couple of tests now that seem to be at that level. There's a test from Abbott and there's one from Roche, and there are a couple of others that seem very close to that. There's a gold standard one developed by a team at Mount Sinai that is a two-step test that really gets to 100% specificity, which means no false positives at all. But if you're trying to do a research study, just trying to figure out what proportion of the population has been exposed to the coronavirus, that's a little bit different. And you can get away with a little bit more rate of false positives there, because your numbers might be a bit off, but it'll still give you a general sense of how many people have been exposed to the pandemic and how widely the virus has spread.
Yeah, and let me just add, I think that this is an example we talked about with smart testing. Right now, I don't see the role of using antibody testing to help any one individual unless you have one of these confirmatory tests that Apoorva just talked about, where you can actually, like we do with HIV, where we have an initial screening test and we have, if you're positive on that, basically it goes to a confirmatory test. So the entire answer is not just one, but it's a series of steps that allow you to know that. Why is that important? Because if I'm trying to advise healthcare workers, have they been infected or not? In even a prevalent population of 10 to 15%, and you have a relatively poor test, and by relatively poor, I'm still talking about one that normally is considered a pretty good test. The chances of telling a healthcare worker, number one, you're antibody positive, but I don't know what that means actually. I think you're protected, I don't know. But then number two, oh, and by the way, you have 1 out of 2 chance that this isn't even a true positive. Now, what are we telling a healthcare worker? What are they going to walk away with? Or what are we going to tell somebody who now thinks I'm protected and I won't get infected and transmit to anybody, and I won't get infected and harm myself? And so my behavior is according to that. I'm more careless, you might say, about the distancing issue. So an antibody test is really a challenge right now where we're at. On the other hand, you can use it for what I call seroprevalence studies. And what I mean by that is that I'm testing 1,000 people in a given area to find out how many are positive. Well, I still have the problem with false positives. But if I follow that same 1,000 people over a year, and every 2 months I test that group, and I have the same lab doing the testing, the error is built into each and every time I'm testing in a similar way. So if I go from 8% the first test to 12% to 14% to 22% over a course of a year, I can actually say there's something going on in here that we've been missing by just doing the virus testing itself. And now I can use that information. This is where I get back to the concept of smart testing. Why are you using it? What's it being used for? What's the application? If people think they're going to reopen with this, I'm very concerned about that, because I don't know any data that would tell me how or why I can reopen. What I want to know is virus being transmitted right now in my community, in my state, and how much. And I think that's where we're still really focusing on the actual virus itself for testing.
We have a question from Bill Graves, who says, are there any prospects of developing a test that people can take quickly at home, safe for kids before they go to school each day?
Well, they exist. They're there now. The problem is, how good are they? And again, what's the margin of error you're willing to accept for the purpose? If I'm sending a child to school who may have mild symptoms of a respiratory illness, and I don't know what it is, I do this, but at least I know it's not COVID. Question is that really true or not? And so this is where we have to come back about smart testing. What are we using it for? What's the error that we're willing to accept? And what does it mean? So I think that has a discussion we've just not had enough of. And, you know, to me, that is where the next stage, the evolution of this testing discussion ought to go is, you know, this is the technology we have. I'm not being critical of it, but let's understand what it can do and can't do. And is this what we should use here now for this question and the answer it provides, and then go from there. So I think we're going to get better tests, but anytime you do a home test like this right now based on antigen without confirmatory testing, you're still going to have a real challenge.
And maybe just we'll take a step back for those who are covering this a little bit for the first time and talk about the margin of error and how people should look for that data. And then maybe, Apoorva, how do you write about that in a way that people's eyes don't glaze over?
Yeah, it's a tough one. You know, so there are different things for each of the different kinds of tests. For the diagnostic tests, what you really have to worry about are what we call false negatives, which means even when you are infected, the test says you're not. And that can be very dangerous because you can go out into the community thinking you're fine and you're really not. With the antibody test, the false positive is a bigger problem. So it's, you know, when somebody thinks that they have antibodies and they don't have them and they think they're protected, which, by the way, that is an answer that we don't even have at all yet. We don't know that if somebody has antibodies that they are protected. We hope they are. We're guessing that they are, but we don't really know. And so, you know, it's putting it in terms like that, but there's just so much uncertainty around all of it that, you know, there's a lot of use of words like may and possibly, and we don't know yet. I've tried to actually include all of those kinds of things in my reporting because I think it's really important that even at the risk of having to have readers understand a lot of complicated topics and complicated concepts, it's better to be accurate than to try and oversimplify and give people the wrong message. And I do thank my editors who are really good at taking out all of the, you know, the confusion or the jargon in my writing and make it even more clear for the readers.
We have a question from Juliana Jimenez who says, how do you recommend addressing disinformation on COVID-19 and the crisis brought on by the pandemic? How do we get people to listen to vetted, reputable information when they're increasingly skeptical of science and more vulnerable to conspiracy theories?
Well, I can just add with certainty that is worth at least another 50 or 60 PhDs. Okay, so we have a lot of work to do to understand that. Remember, we're operating not just in a COVID world, we're operating in an anti-vaccine world, we're operating in an anti-climate change world, we're operating in a world that has many, many different issues. As they can tell you at the Times, we surely have been dealing with this. We just published a story yesterday on SIDRAP News about this whole controversy about where did the virus originate from. So when I was making the comment about Mother Nature making the virus, I saw Paula's eyes glossing over a little bit because she knew, oh my, don't go there and say it's man-made, because it's not. I mean, the data are, I think, absolutely overwhelmingly in favor of a animal to human jump that occurred in the normal everyday setting of life, not in a lab as an escape or whatever. But I mean, you can't know how this story has taken on legs of its own. My worst hate email surely have come in over this story where people are convinced that I'm part of the deep state trying to undermine this administration from a virus that was made by the Chinese government to do that. And no amount of information that you can provide on a rational, thoughtful basis convinces them to the contrary. And so I think this is a huge challenge. And we have a lot of work to figure this out. And if we figure this out for COVID, we will obviously hold the keys maybe to figuring out a lot of other issues right now around the use of science-based information and decision-making and how we live our lives. This is a huge challenge, a huge challenge.
If I may say something on a slightly more positive note, I mean, I think it's true that it is a big challenge, but I would like to think that because of this pandemic, there will be a newfound respect for disciplines that people didn't really think much about before, like public health and epidemiology, virology, immunology, that these become things that people become, a little bit more familiar with. What is an antibody, and, what is an antiviral drug, and what's the difference between a virus and a bacterium? Hopefully there will be a little bit more appreciation of those things. I've also noticed that I think within the journalism world, there's a newfound appreciation for science journalism and for people who can actually report on these things. So, you never know. If newspapers do survive, maybe there will be more science desks, more reporters dedicated to covering science because of the pandemic.
And Apoorva, I wonder, at the Times, because there have been so many rumors, they're calling it an infodemic of rumors that have been so virulent and so pronounced in people's beliefs. What kind of internal discussions are you having with your editors about, do you cover it? Do you not cover it? Are you giving attention to it? How do you make those calls?
I mean, that's really a question more for editors, but I would say, yeah, we absolutely are paying attention to what are the conspiracy theories out there. Whether it's was the virus made in a lab? Is the virus mutating? This documentary that's been going on called Plandemic, we've covered all those things, and we've addressed those conspiracy theories head on, and really explained the science behind them and why that theory is not accurate. I think there's quite a bit of that we have taken on, but at some level, we're not going to get to the level of are vaccines good or bad, because that debate has been sort of put to rest. Or we're not going to sort of revisit just the way that we wouldn't revisit climate change all over again. So there are some new questions that have come up with the coronavirus that we're definitely addressing, but with some selective input.
And we're officially past our time, but Dr. Osterholm and Apoorva, do you have time for a couple more questions? We have a lot of them here.
Unfortunately, I have to run. I have another commitment at the top of the hour here. I apologize.
Okay.
But
yeah.
I'm sure we'll handle the questions for both of us wonderfully. So I'm more than happy to cede my time over to you. So thank you. So thanks for having me on. I very much appreciate this. This was a great opportunity to share the stage with you, Apoorva, and also to help journalism help us do our job better. Thank you.
Thank you so much. And Apoorva, do you have time for a few more questions?
Sure. I can try to handle
them. So we have one kind of technical one, which was on pooling techniques that allow you to do 5 to 10-fold more PCR tests for screening at workplaces and schools where positive rates may be 1% or less. And what's the the latest thinking on that?
I'm not sure, actually. This is one that I'm not that familiar with. I know that there are countries that have thought about doing this. I mean, India tried it, and some other countries have tried it, mostly because the tests weren't really available to try and figure out, where within a cluster. I've seen it mostly as a speculative thing, and I don't know how well it has worked in practice. And I think, it's one of those things that sounds good on paper, essentially.
I have a question from Anna Boyko-Weirach, who said, is there an equivalent of preprints for local case investigations on disease transmission, or a way to obtain information on local transmission through a public records request?
Well, so there are multiple things in that question. I mean, can you get information about local transmissions? You should be able to from the local public health agency and find out information. What the question about preprints is separate. I mean, there is a preprint server that's dedicated to medical results. It's called medRxiv, MEDRXIV. And they actually do try to vet the reports that they're getting through by looking at whether, the researchers followed the right kinds of protocols, and, did they get ethical consent? Because those papers have a little bit more medical importance, they do try to be careful. And there are a lot of case studies on there, that's for example, where all of the case reports about testing hydroxychloroquine or any of the new antivirals that people are testing, that's where some of those reports have come up first. All of the reports about the nature of transmission of the disease between people, in Wuhan and in Italy in the early days. So there's information available there, and that's freely available. Anybody can access that. As far as the public information request, I think that has really depended on which department and which public health agency you're trying to get it from. Some of the agencies have been pretty open with FOIA requests and getting Freedom of Information Act requests fulfilled, and some have said, oh, we're so busy actually managing the epidemic that we don't have time, which is really an unacceptable answer.
And we'll have a final question here. It's from Jeffrey Mazike, who's a physician who works in a small town. And I think his question also has relevance for reporters. He says the economic base of his town is tourism. And what I found is that the business interests try to grab any straw possible, first hydrochloroquine, now the antibody passport, which they believe will open up the town. Every day I fight the battle to explain the flaws of antibody testing. Any ideas how I can address this?
I think you can point to the FDA and the CDC, who have both now put statements on their website, offering guidance on when these antibody tests are helpful and when they're not, and also what they can tell us and what they can't. I can offer the reporting on the New York Times. We've done a lot about this. I think that the immunity passports, it's another idea that sounds good on paper. The idea that somehow you take a test, if you've been exposed, and now you're free to go. But there are, many, many, many questions. There are about 50 questions to answer between I have a positive result and I'm immune to the virus. And one of those is how long the immunity lasts, but we also don't really know if everybody who is exposed to the virus makes antibodies. We think probably that's the latest evidence we have, but we don't know if those are the good kind of antibodies, if they're powerful antibodies that actually neutralize the virus. Again, there's some preliminary evidence suggesting that's true, but we don't know. And we don't know, if that immunity lasts long enough until, for at least a few months. So I think these are the things that you could try to explain, whether it's a journalist or whether it's an official in a small town or a doctor, that these are all the unknowns and, all of the sort of subtleties that get lost in just, oh, I have a yes, no answer from this test. It takes, I think, time to walk people through those steps, but it's important.
With that, I'm going to thank Apoorva and thank in absentia Dr. Osterholm as well, Professor Osterholm. This has really been a very informative discussion, and I want to thank our audience too for their excellent questions. If you would like to support webinars like this, we have some information below. We do count on individual support as well. And just want to let you know that we'll be posting the webinar on our site, centerforhealthjournalism.org, later today. We'll also be sending you a quick survey and ask you to complete it to share your feedback on this webinar and your ideas of what would be most relevant to you for future ones. And I want to thank everybody for joining us.
Thanks for having me.